Hey, Miranda, Kelly, and Aaron, if you're on here, I am in my car, obviously. The office that I came to, I thought was unlocked and it's not. So when my colleague gets here, I'm gonna run into the office. So might be off camera for just a minute, but I don't think it should affect anything with the meeting.
No worries. It's just now 1:30 and we're still clearing out the waiting room, so we'll give it a few minutes before we get started. And if you
Sounds good.
disappear on us, we'll know that you're getting settled.
Yes, just in transit. So I see that Miranda's on. Do we have any of our other TAC members?
Arthur's on, and I think that's all I saw, but I'm scrolling just to make sure. Sometimes when people come in bulk, I don't catch everybody.
Yeah, I know. I have the same issue with Zoom. Hi, Arthur.
I believe it's just the three of you currently.
Okay, thanks. It looks like it's 1:30 now, maybe 1:31, and we'll give it a couple more minutes to see if our other tech members can join us.
I thought I
And
saw Arthur's name when I first joined too, but I don't see it anymore.
sometimes his connection, he may have dropped, and hopefully we'll be able to come back in. My key has arrived, so I'm going to go off camera for a minute.
We'll wait for you to get settled before we get started. The waiting room's still clearing out.
All right, I'm in.
Okay, the waiting room is cleared, and I just currently see yourself and Miranda logged in. I can keep you posted for other members if they join.
Okay, yeah, please do. We won't have a quorum unless we have two other members join. So we may have only discussion today, but that'll work too. Well, thank you all for joining us today. Welcome everyone, and hope you're enjoying this nice sunny day. Hopefully it's sunny where you're at in Kentucky. I'm Emily Beauregard. I'm the Director of Kentucky Voices for Health, and I'm the Chair of the Consumer TAC. Miranda, why don't you go ahead and introduce yourself?
Hi everyone, I'm Miranda Brown. I'm the Outreach Coordinator for Kentucky Equal Justice Center, and I am a connector or a certified application counselor. I'm a member of the TAC.
And we don't have a quorum, but may come back to that if other members join. We also won't be able to approve the minutes, or the
Up,
meeting
up
transcript.
there she is. She beat me to it. We have one more member.
Oh, good. Hi, Christy. Good to see you. Christy, we were just doing introductions. If you don't mind just quickly introducing yourself and who you represent.
Hi, I'm Christy Harden. I'm the Youth Service Center Coordinator at Bullitt Central High School. I'm also on the Frisk Coalition.
Great. I'm glad you could be here with us today. We are close to having a quorum now, so when we get one other member, we should be able to do some voting. And we'll just come back to the minutes in the event that we do have somebody else join us. We can start with old business and some of these standing data requests. who from Medicaid is going to share that data with us?
This is Jordan from eligibility and enrollment. I can speak to some of the numbers really quickly. So we currently have, under traditional Medicaid, we have 145,548 individuals. In our MCO population, we have 1,414, 817 individuals. For presumptive eligibility, we have 1,361 individuals, and for emergency time limited Medicaid, we have 234 individuals. I think Veronica wasn't able to attend today, so I'm going to go through some of the renewal information. So for February renewals, we have a total count of 93,462 individuals with a renewal due in February. Of those individuals, 87,268 were processed through passive renewal. 23,368 had an RFI along with that passive renewal. And then the number of individuals who were sent renewal packets are 6,194. For March, we're expecting 97,907 individuals to go through renewal. These aren't finalized numbers yet, but the projected information is that 95,000 of those will be processed through passive and around 2,100 sent a renewal packet.
Jordan, that seems like a higher passive renewal rate than we had for many months in 2023. Is that accurate?
So it is a higher passive renewal rate. We made a lot of we made some redistributions of cases from December into later months. So that's causing kind of these later months to have a higher passive renewal rate. And we also made some system adjustments just to ensure that all the individuals who are eligible for passive renewal are getting put through passive renewal. Yeah, so we're pretty happy with that passive renewal rate. That's great.
Yeah, definitely an improvement, because we know that means more folks are going to be able to keep their coverage.
Absolutely.
Any questions about the numbers that Jordan just shared with us? Okay. Well, we appreciate that update. Did you have any other updates related to renewals? I know we have some items and maybe under new business that we're going to touch on later, but
I don't have any other updates. I mean, we are working on our SSI population and individuals who are transitioning to APTC. We're taking a look at systematically how that works and what we can do to kind of make sure that we give them an opportunity to report changes prior to their terminations. So we are making changes related to that. But other than that, I don't have anything else to report.
okay. Yeah, that's helpful. Would reporting those changes, would that be still through Connect, through the self-service portal, or would there be another way in which you'd be encouraging people to report those changes?
So the plan is to send them a pre-populated renewal form. But they could also report changes at any time on the self-service portal, and we're making changes to ensure that specifically the SSI members are able to access their cases on self-service portal as soon as possible. Because normally the SSI individuals, their cases are locked because they're normally handled by Social Security. You know, if they're eligible for SSI, then they just get the Medicaid along with it. So we're making changes to allow them to hopefully immediately after we receive that termination from SSI that they're able to go in through self-service portal.
Okay, that's good to know. And Arthur, welcome. I'm glad you could join us. Did you hear that SSI update from Jordan?
No.
No. Jordan, would you mind repeating that? I think that's information that Arthur would want to hear.
Yeah, absolutely. So we are working on changes to our SSI termination timeline. We're going to be sending individuals who we receive an SSI denial, we're going to send them a pre-populated renewal packet to give them a chance to report changes prior to their termination. They're also going to be able to access the self-service portal after we receive that termination, so they can use that pathway to make changes and reapply or renew if needed. And then we're also doing that same thing for our individuals who through passive renewal would transition to the advanced premium tax credit off of Medicaid. We're going to do that same process. They're going to get a pre-populated renewal form. These changes aren't necessarily in place right this second. We're making system changes, and then we're doing kind of like additional outreach and sending kind of a generic renewal packet in the meantime until we can get that updated systematically.
He said, thank you.
No.
Right now, he can't. You ain't.
Yeah.
He said right now he ain't feeling good.
But
That's why he was late.
Yeah.
Oh, that's why he was late getting on. Thank you.
Well, I'm glad you could join us, Arthur. And we had just gotten started, really, so you haven't missed much. We actually can go back now and establish that we have a quorum.
And Melanie is trying to log in.
perfect.
She
Okay,
has
then we'll wait
issues. So
on
I've got
Melanie.
Kelly. I have Kelly trying to copy the Zoom link in an email to send to her to see if that helps
Okay.
get her on.
Well, if she's going to be a little bit later, maybe we should go ahead and just make a motion for the minutes. I guess I should ask first if people have reviewed the transcript, if you have any questions or any, if there's anything that you think needs to be corrected before we go ahead and motion to adopt them. Okay. It is a pretty accurate recounting since it is a transcript. So I'm going to ask for a motion to approve the transcript from our December meeting. I
And
think-
motion to approve the transcript from the December meeting.
Thank you, Miranda. Second?
I will second it.
All right, thanks, Christy. All in favor, say aye. Aye. Any opposed? All right, motion carries. So it looks like we've covered the standing data request. We talked a little bit about Medicaid renewals. And next on the agenda is the HCBS rate study and the PDS rate increase. Any updates there?
Emily, do you want to go back before we do that? Do you want to do the wait list? I think right above
did I
that.
move
Oh,
that? Or
yeah, I think
did
that
I
may
miss
have been
that?
right above that. So
Yes. Yes,
so
Pam, you can feel free to cover any of the topics
okay.
that you
Okay.
want to cover here. Thanks.
And I am going to share with you a document. I was working on it to try to make it pretty to be able to send before the meeting, but I got pulled into something else. But so I'm going to share these numbers. I'll give them to you verbally, but then I'm going to, I will give you all, I'll send a copy of the wait list. This is numbers as of February the 7th, because that was the last time I pulled all of the numbers. We have 3 waivers now that have a wait list. ABI LTC has 1
Pam, we're
individual
not
on the wait
seeing
list.
your screen.
Oh, I don't have it
It
to
looked like
share.
you were starting to
So
share and then the agenda popped back up.
actually,
So
I don't have it to share right now. It
Oh, okay.
is a jumbled. I can show. Let's see here.
I
I'll
thought
show
you
you
said
my
that you were gonna
jumbled.
show us
I have
something.
one I'm working on that is a and I can't even get my camera to work. I was going to show you what I was. Oh yeah. So look, this is awful. I'm in my office, so my setup is completely different. So I have like this lovely piece of paper that's not very it's not very pleasing to the eye. So I'm working on getting something put together, and I'll send out to you all that
That's
we'll have it
absolutely
on.
fine. We're good with a verbal report.
Okay. So right now, ABI LTC has 1 person on the waiting list. HCB, there are, as of 2/7, there were 833 on the waiting list. Michelle P, there were 8,872 on the waiting list. and SCL, there was 3,414. None of those individuals for SCL are on the emergency waiting list. But we did a deeper dive into the waiting list stats, and this is some information that I wanted to share with you all, and that will be on what I send out to you. Is we looked at, of the individuals that are on the wait list, who is receiving services in another waiver, and who is Medicaid eligible, meaning so they may not be getting waiver services, but they're eligible for other state plan services. So for ABI LTC, the one individual that is on the wait list is Medicaid eligible, and they are receiving services in another waiver currently. For HCB, 79% of the individuals on the wait list are Medicaid eligible, but less than 1% are receiving services in another waiver, which, if you think about it, makes sense because that target population, really HCB is the only waiver that is serving that specific target population. For Michelle P, 84% on the wait list are Medicaid eligible, 26 are receiving services in another waiver. Something else to think about with Michelle P is that over 70% are children and have access to third-party medical coverage through their parents, where they may be getting some services. For our individuals on SCL, 93% of the individuals on the wait list are Medicaid eligible, and 59% of them are receiving services in another waiver. So we've been working with our partners in BDID and developing kind of a standard way to report this, so that we're giving this additional information to go along with the waitlist statistics. So I will get that out to you all, and it's something that we're going to start publishing too, so that it's available, so that, you know, we'll do it once a month, just because the numbers change daily. So we'll pick a day, either we'll do it, you know, as of the end of the month or the first day of the month, but we'll make sure we say what that is, so that people have access to that information. But I thought it was helpful to also know how many people were getting services in a different way, in another waiver, so they're not going without services completely, as well as how many individuals were also Medicaid eligible. So hopefully you all found that helpful.
I was muted. That's good to know. Thank you. Are there
Arthur,
any
did you have
updates
any
on the?
questions? I was going to ask you. I was just going to make sure Arthur didn't have any questions on wait list, and I apologize, Arthur, that you're not feeling good. I hate that.
Please.
W- Will be fined for FINN
I
A
am
FINNA
uh,
finalized?
uh,
Oh, finalized.
uh, uh,
He was asking when is HCBS rate and study and PDS rate increase will be finalized.
Okay, so the rate study is with executive staff, so way above any of us. And I do believe, although we do not have the final, you know, we do not have the final budget, but once we receive the final budget, then I believe that rate study will be finalized. In the interim, we renewed, if you all remember, on November the 9th, we submitted all of our waivers to CMS to make permanent the Appendix K rate. So that was that 20% increase and the 50% for residential. And then also for some of the services, if the provider signed an attestation, it was also a 50%. And that attestation guaranteed that they would pass on at least 85% of the rate increase onto the direct service provider. So those rates will remain permanent until there is a new change. As far as the PDS rates, Arthur, if you know of anybody that's having trouble, or anybody, if you hear that they're having trouble getting that, as the participant and employer, they want to give their employees a raise and they are having trouble getting that done, if you all will contact us, and we will help work through that. But that should be in place right now, that if you, as the employer, as the waiver participant, or with your rep, in the cases of individuals that are children or that have a representative that works with them to help do that, if they reach out to their case manager, support broker, service advisor, we call them about 5 different things. If you all reach out to them and you're having trouble getting that done, let us know and we will help with that. But you should be able to raise it to the current max rate, if that's what you choose to do.
What if someone want to have 10? In? Oh, what if someone wants to have input? Is this it? Sorry. Is it too late to have an input on that?
It is never too late, Arthur.
He said he has about 4 people who want to have input in that, and he will tell them that it ain't too late.
So there's going to be, so at any point in time, Arthur, you can email me, or anybody can email us. I put the Medicaid public comment email address, except I spelled it horribly. It's ky.gov, not kyg.of. So let me fix that really quick. But there will be also another, when we update the rates again after the rate study is made final, there'll be an official public comment. But Arthur, I'll tell you what I tell everybody is that anytime you have a comment or something that you want to share, please reach out to us and tell us. We compile all of that and we use that information all the time to think about changes that we need to make, quality improvements that we need to make. And so we use that information, and we review every single thing that comes into that box. So you can give them that information, or you also, Arthur, have my email address, so you can email me as well.
It says okay. This is this is of well, okay. Oh, this is off the record. But he wants to thank you for wishing him happy birthday. For wishing
You're
him
welcome, Arthur. I'm sorry I didn't get to come and see you in person that day.
he didn't
yeah, yeah.
He didn't say that.
I'm not this bad. Ah,
He didn't say that on people time
yeah.
meeting
Ah,
time.
yeah. Yeah. I,
That was just off the record.
you.
Thank you.
Thank you, Arthur.
Arthur, keep in mind too, that if you ever want to provide input on the record, we can make a recommendation through the TAC. So just keep that in mind if there is something specific that you want to recommend to improve the PDS rates for that process. Anything else about the rate study or the PDS rates before we move on?
No, I don't know if you want to go on and just to keep the waiver stuff together, if you want me
Well,
to
let's
go
do
on and
that.
speak out about 1915I. So I'll talk about 1915I, and then I think Leslie is on, or someone to speak about the 1115. But the 1915I state plan amendment is out for public comment right now. So plug for that. It is out for about another 9 days. There will be another reminder going out within the next couple days about public comment. There is on the website, in addition to the SPA, because we realize those things can be incredibly difficult to read, but it's the format that we have to use. There is a guide that talks about what is in the SPA, as well as the recordings are out there for the town hall or those stakeholder sessions. There's a recording that's out there, as well as the deck that is out there. But our goal is still to have public comment responses in or back out, and to have the SPA into CMS for their review by mid-March. And I believe, I've talked to CMS. I don't believe they've scheduled it yet, but we are meeting with them in the next couple weeks to talk about the SPA as well, to hopefully facilitate the review of that, and what we're wanting to do. We're very excited. It's been a long time coming for these services for individuals with serious mental illness, and there's a limited subset of the services that are also available for individuals with substance use disorder. And of course, it's in companion with the 1115 waiver that Leslie's going to speak with, so individuals can receive both of those services. You will not be able to get 1915I and one of our 1915C waivers at the same time. So.
But the combination of the 1915I and the 1115C can.
And I think it's just, I don't
Well,
think
work
there's a
with.
C. I think it's
1115.
just an 1115.
Oh, sorry.
No, that's
Yeah.
okay. I mean,
We always say 1915C. I think I probably just had C it.
well, Medicaid's very good about acronyms, and we like to.
I was just reading the agenda. Now that I
Yes.
look at it, I'm like, yeah, what's that there
Yeah,
for?
so I'll let Leslie speak to the 1115.
So as
Thank
far as the
you.
1115, as Pam said, it's a companion with her 1915I, and it was the only authority we could get things like recuperative care. And that was, the example was, sometimes in the federal world, they call that like a medical respite. And that's where a person, say, who's homeless, needs a safe, clean place to go before or after maybe a hospital procedure, needs time to recuperate, or needs time to prepare, those days or two that we all have to go through preparations for maybe a surgery or wound care and things like that for a day or two. So that's kind of where we call it recuperative care, and that's the one that's in the 1115. We do have parity for IMD to allow for up to an average stay of 30 days in Kentucky, and that's kind of parity on what we did on the SUD side already. I always mention too that there's a possibility that Pam and I can work in conjunction with the SMI once we get it approved to assist in the Money Follows the Person or Kentucky Transition, to be able to assist with some of those SMI transitions for the first time. But we have to get the 1115 waiver approved before we're allowed to do that here in Kentucky. So those are exciting. That one's been turned into CMS for quite some time, maybe the end of May. And then the reentry, if anybody's wondering about that, it came out from under federal public comment February the 11th. So we're waiting to hear back from them on that one as well. They may be now looking at a few things because we've had just a little bit of conversation with CMS that leads me to believe that they're probably taking a look at the things that are sitting and waiting now. So that's always hopeful to get to the point where you really start the negotiation and the work with CMS. So excited about that as well.
That's great news.
So that's just real quick, it's 1915 I and 1115 waiver. And then the I is a state plan amendment. I know it's all confusing and this is all new, right? Because this will be the first I we've had in Kentucky, if I'm, as far as I know.
Yeah, it's one that I wasn't familiar with before you started.
Exciting times.
Yeah. Thanks for those updates. Any questions?
I'm sorry, did you say parity for IMD? I'm not sure what IMD is.
Institute for Mental Disease. And so we have a parity in the SUD that we extend the bed stays past 15 days and up to an average stay of 30. And we had not done that on the SMI side. So not only did we want to do it, but it was really parity, which was to give those folks the same opportunity as we have in the SUD waiver or SUD 1115 waiver. Parity just means, saying that we're trying to meet the same equality across the board, equity.
Thank you.
Yes, ma'am.
Thanks, Leslie. And Melanie, thank you for joining us. I think we've got 5 of our TAC members on now, so that's fantastic.
I apologize for being late. I couldn't get on. And thank you to Ms. Vickers. She helped me to get on. So thank you so much.
I think that we've just finished, unless you have any questions related to the 1915 I or the 1115 waivers to provide supported housing and employment to people with SMI with severe mental illness or serious mental illness. Do you have any questions related to that before we move on? Okay. I think if we jump back up, the next item was the 2022 preprint for the hospital rate improvement program. When I think it was at our last meeting, we had talked about ATRIP, the hospital rate improvement program, and the preprint came up quite a few times. And so we wanted to, see if we could better understand what's included there and just be informed about how that process works moving forward.
Sure. This is Angie Parker. I am the Director of Quality and Population Health. I'm going to keep my camera off while I do the presentation because I might get too close to the camera and I don't think that would be a good look. Anyway, let me show you. Hopefully we are seeing the same thing, but
yes, we can see it.
all right, so we're going to talk about the hospital rate improvement program results for 2022, but to start, what exactly is the hospital rate improvement program? It's actually a directed payment program that allows Medicaid to provide additional payments through managed care to advance the goals of Medicaid program. It's based on utilization and delivery of service. It's to advance at least one goal of our quality strategy, of the DMS quality strategy, with appropriate oversight to evaluate progress on the goals. It's evaluated at the end of each program year to measure progress on achieving outlined goals. We have to submit the preprint to CMS annually. So any changes or what our results were from the previous year need to be submitted to CMS annually, and they have to give us the approval moving forward. And sometimes they'll come back with questions on certain things, and we would have to answer those. But so far, we've been doing very well. We're working on 2025, actually preprint now with regarding the hospital rate improvement program. And the hospital rate improvement program is funded through a hospital assessment, and there's the KRS that addresses it further. But basically, this is paid via federal funds for the most part. And why it's called directed payment is because we tell the that we basically direct the MCOs to take this payment. And there are two main objectives to directed payments, and that is to improve quality outcomes and to maintain access to services. So when you're thinking about the hospital rate program, as I said, we have to, it has to be associated with our quality strategy that we did a couple of years ago. And it also helps the hospitals stay and working for us in where they are located. But the 2022 HRIP program, and actually, BMS, we work with Kentucky Hospital Association on developing the blueprint. They are I guess you would say, the overseers or the leaders of all the hospitals that are associated with this program, and helping bring in all the information and assist each hospital with their quality metrics. And they're kind of the go-between on any questions that the hospitals may have. So in 2022, 84% of the hospitals achieved at least 4 of the 5 hospital-specific goals, and 50% achieved all 5 hospital-specific goals. So what were those goals? These are the data metrics that for 2022, catheter-assisted urinary tract infection standard infection ratio, also known as CAUTI, and then low volume, C. difficile standard infection ratio, C. difficile low volume, hospital readmissions, 30-day all-cause, and sepsis screening at triage and bundle compliance. You see, I have a few asterisks up there, and it basically explains who's included in those data metrics. So for the CAUTI standard infection ratio, it excludes psych, rehab, long-term care hospitals, also known as LTACs, critical access hospitals, low volume and low volume birthing hospitals. So on the next 2 slides, you will, or one of the next 2 slides, where we're talking about CAUTI, you may see that the math may not jive, and it's because some of the exclusions in those certain groups. Also, there are psychiatric specific measures with the hours of physical restraint, hours of seclusion, admission screening, safe use of opioids, which involves provider education, rehab specific measures, which is discharge to community, and then the social determinants of health screening. So this is a whole list, and it's not as easy to see, but it provides all the quality measures that I just went over, what the benchmark is, and what the hospital goals are for these particular measures. And this is again 2022. I'll let you look at that for a second there. But for example, the benchmark was to be established in 2022 for current e-prescribing, SUH screening, hours of seclusion, hours of restraint, admission screening for violence, and discharge committee. So 2022 is basically used in order to determine a benchmark for which they would be measured. And here are the results. Hoping you see these okay. The 30-day readmissions, there's goal A and goal B. And basically, for the most part, saying readmission percentage of providers who met the goal. Sepsis screening, did very well there. Safe use of opioids, 93%, 86%. The catheter assisted UTI, 70%. And for low volume non-rehab, 98%, and low volume rehab or LTAC, 61%, and the body low volume, 91%. The rest of the goals, results, C. difficile, 73%, C. difficile low volume non-rehab, 100%. C. difficile volume rehab or LTAC, 69, C. diff low volume, 92, social determinants of health, 91, hospital hours of physical restraint use, hours of seclusion, screening for violence, and discharge to home community all at 100%. You see that the numbers here for those that were eligible.
Angie, could you tell us a little bit more about what happens with the hospitals that aren't meeting the goal? Or if you identify one of these measures where there's just kind of low performance, generally like the one that was 60%, is there work done to, together in a coordinated effort to try to get those rates up?
HA does, works with the hospitals. They hold, quarterly meetings at a minimum with the hospitals on where they're tracking and how to help and to improve those statistics.
And is that social determinants of health measure, is that a screening? I think that's what I remember.
Yes, it is a screening.
Is there going to be any like sort of next step in terms of referrals that will be required or encouraged?
That's part of the screening to see, okay, this person does need, housing assistance. So they're supposed to take it that next step and do some referrals. And, can use the Connect tool, or they can use the CMS tool in doing that SDOH screening. But for the first year, like I said, it was basically establishing a benchmark, getting the hospitals educated and what tools to use and how to best move that forward. But for 2024, it'll be looked at a lot more intently and how that is being managed.
Okay, thanks.
Angie, in the chat, Melanie asks if the information is for all hospitals. Oh, sorry, Melanie, I didn't mean to cut you off.
And I apologize, and thank you so much for helping me to get on. I just had a question. You know how there's level 1, trauma level 1 down to level 4, what is it, 4? Are all of those hospitals included in this data collection, or is there specific ones, like community?
The hospitals, except for the University of Kentucky and the University of Louisville, they are not included in this. They have their own separate directed payment program. And it's those hospitals that are associated with the Kentucky Hospital Association.
Oh, thank you.
You're welcome. Any other questions before I get to the last slide? And this is basically where you can find the quality strategy. It says here it's a draft. It is no longer a draft, but this was Emily contributed to this, the quality strategy of Kentucky, and it's reviewed at least annually. And as I said earlier, the directed payment program does have to be associated with some aspect of the Medicaid quality strategy. This page also shows you other quality reports that we do, either via IPRO, primarily our external quality review organization. So you can always go in there and see the reports that have been completed and what the status of those. And you can also see, the MCOs are to be accredited via NCQA, and we keep track of their accreditation requirements. But that is
Thanks,
all.
Angie. I know that the Medicaid website has changed quite a bit, maybe the entire cabinet website. Would you mind just putting a link to that quality strategy page into the chat for us?
Absolutely.
That would be great. Thank you.
And figure out how to stop sharing and I'll do that.
Yeah, and I'm very curious, just from our consumer tech lens, to learn more about what hospitals are doing with the social determinants of health measure and the referrals, and then, any sort of future measures that will be going in that direction.
Sure. I'll get that. Yeah. Of course, our value-based purchasing program with the MCOs is associated with the quality strategy. So there's a lot of associations that have qualities.
Right. And I know that when Deputy Commissioner Judy Veronica Cecil was on, I think it was our last meeting, maybe the meeting before, there was some discussion about trying to really kind of align all of the quality work being done and look for opportunities to have more stakeholder input there. So I don't know if that's a conversation that we can have today or not. Did I hear that she's not going to be able to join our call?
Oh, I don't, I did.
I think
thought
she had
saw
to
her on
drop
here.
it too.
Oh,
I'm sorry.
okay.
Yeah, so maybe that can be on a future.
Well, I mean, I
agenda.
can tell you in general, yes, to that. We are looking at aligning quality metrics across the cabinet, as well as within the department. And as well as what we're doing with the MCOs and what the directed payment programs are looking like, so that we have one. I mean, we would love to boil the ocean when it comes to quality, and we'll continue to do those, but there will be more of a focus, probably more so on children, maternal health, and children getting their immunizations and their well child visits, babies being, born healthy, and the main chronic condition would be diabetes that we'd be targeting.
Okay.
But that's still up, to be determined and discussed throughout the cabinet, and looking at the work that we are doing as a department as well.
Well, as far as engaging stakeholders in that work, is there an idea of how that would happen? Would that be regular meetings? Would it like some sort of advisory council? Would it be just through various like interviews or surveys or?
That's really to be determined. Obviously we do welcome your input on how these things are determined as far as quality and healthcare. Obviously, you all are out there and hearing from people. And at any time, you can always reach out to me if there's concerns or regarding or you think there's something we need to be focusing on. By all means, you can contact me.
Yeah,
but to your exact question, there's not that hasn't
it was
been
something
determined
that
yet.
I think Veronica brought up as we'd like to do this in the future, and I wasn't sure if there was like kind of a specific idea around how that was going to function, but
It's in the thinking process right now.
Got it. No, that's good. Thank you for that update. Any questions related to that before we move on? The next item here is probably also one that you'll cover, Angie. The network adequacy issue, the reporting process for Medicaid members. I think you all are calling it an access to care reporting form, or I can't remember the exact term.
Did you all get a copy of what that looks like?
Yes, thank you.
And so have you had an opportunity to review it and have any feedback on that?
I know Miranda had a number of suggestions and some questions, and I had a couple as well, but Miranda, do you want to cover yours? I mean, I think it's a great idea and a great start. I just want to say thank you for working on it.
Now I'll say our health plan oversight team put it all together, and I just made some edits. So I have to give credit
Thank you
where
to your
credit is
team.
due. So what have you got, Miranda?
Yeah, thank you so much. I was just finding my notes. So, the top of the form explains that it's for people to report issues, but does it serve as a request for Medicaid to cover the provider or the appointment that the member lists on the form, or is it just to report? It was kind of unclear. There weren't really instructions on the form for how to use it.
it is basically to know what type of provider they were needing to see, but weren't able to get an appointment.
Yeah, related to that, Miranda, if I know you have a few other things, but my thought was that it may be a really good opportunity to educate people about network adequacy rules and, you know, what those time and distance standards are, because otherwise, you know, if you don't set that as the expectation, people may think that waiting a week for an appointment is too long, or, you know, you just don't have any parameters. So I think if we can be a little more specific, so that people can determine, you know, does this apply to me or not?
Well, it's the reason I laughed is like, I don't, I had them take that out because I was thinking, because they don't know what they are. I mean, we're trying to keep it to one page, and I think he's like,
Right.
okay, 30 days for, you know, urgent, emergent, then you're going to have to explain what urgent it is and an emergent, which is not necessarily a bad thing. I mean, you know,
I would
anybody
even
can use
maybe
the
just link
education
to,
for that, but, I mean, we can certainly add that. I don't think it's a bad idea. I think it was just a matter of, well,
trying to keep it
that way
simple.
they can, you know, even if it is just a week, you know, and they need, depending on what their condition is, it may need to be addressed sooner than 30 days or whatever. But we
Well,
can
and that's a good point, as long, you know, and you all could then kind of categorize them into different buckets as far as what the issues are. But I guess back to Miranda on some of your other feedback, I kind of had a similar idea of like, maybe there's a little more education that we can do up at the beginning.
Yeah, no, thank you for adding that, because I agree. And yeah, just for people to understand exactly what they're using the form for and how long they should, like, are people supposed to expect a response from DMS when they submit the form, just to help clear up expectations about what am I using this for and what's going to happen after I submit it. And then my other comments were related to, I could see people needing a little bit more instruction on how to complete the provider section. Just because it wasn't super clear to me if I was trying to imagine if I was a patient filling it out, that it would be helpful to clarify, you know, put the information for the provider that you're trying to see, not one that you, yeah, it just wasn't super clear in itself. And then it'd be helpful to include information about the process, either on this form or on an accompanying document. And then it says complete all fields for both sections, but if a provider has offered a member multiple dates and the member is waiting to confirm if they'll be covered or not, like, it was kind of confusing to me. I was like, well, what if there's multiple date options? Do I put them all, or should they, yeah, that part wasn't clear, but it kind of goes with the whole section. And then I just had questions about how will members be made aware of the form and how will members access the form and versions of it in other languages.
it will be in Spanish. That's an easy answer. It will be on our website. You can email it, and that email address will be coming to someone in my quality in a quality branch into the Quality and Population Health Division. But you know, if we have putting it on the form, we will probably have to have a, you know, to your point, some education what that is, and obviously we would, you know, give this information to the TAC members and providers to make sure, or not members, I mean, not providers per se, but advocacy groups to let them know that it, you know, if they contact you, here's how you can help, potentially get help. But I appreciate your feedback on this. And if you have it in an email and want to send it back to me or Aaron, well then,
You know,
we can
one
most
other
certainly.
thought that I had about how it could be accessed and completed is that making it a fillable form rather than a form that you print off and email. I mean, it could be a
We are
two-version.
going to do it. That is part of it.
Okay, good. Because
will
I
be.
think one, you can build logic into a fillable form. It can essentially be like a Google form or a SurveyMonkey, you know, any Qualtrics. but you can build in, you know, if they answer yes, then you ask another question versus if they answer no, you know, you move on. So it could make the form shorter for some people, get the detail that you need on others. But it's also just a nicer way of, I don't like to download and fill something out and email it in. So I know other people probably feel the same way, especially if you don't have like Adobe or, you know, those kinds of PDF readers with editing capabilities and all of that. So I think this is a really good start. I'm glad to hear that it'll be a fillable form, and we can collect all of our feedback together. I know Miranda's written hers down. I've got a few ideas, and we can put that in an email to you, Angie. Do other folks have questions or suggestions?
Um, Emily, this is Melanie. I put in the chat possibly to put some of the language in what they call plain language, so that there's an ability to for all levels of cognitive ability to be able to access it.
Yeah, that's a very good suggestion. We should always be thinking and working in plain language.
Yeah, it should be at a minimum 6th grade reading level. Sometimes it is challenging depending on what, you know, you're trying to.
Yes, lots of terms are
Yes.
not that easy to distill, but we often just, you know, describe something and use the term and then describe it in plain language. So, and I know the cabinet has done a lot of work on notices in plain language recently, so I think that's something that we're getting a lot better at. Happy to also, you know, review another draft. I think that would be great. But
Sure.
we'll get you that feedback. The
Hey,
next
Emily.
item. Mhm.
Sorry, Emily and Angie, this is Rachel Rarick with DMS. I put in the chat, I just want to make sure that that was looked at as well, that one potential suggestion would be to have the form very simplistic and fillable, but also have an accompanying document with the instructions where we can go into more detail. So that way, when they're posted online next to each other, if they have those questions, they'll have that as a reference. That might be helpful.
I think that is helpful. And something else that DMS has done in other situations is videos, just as another way of making it accessible for someone who maybe is illiterate or just needs a more visual version of an explainer, you know, kind of walking you through the process. So if that's something that could be done relatively easily, I think that would be helpful too.
We'll look into that. Thank you.
Maybe that's more of a KHB thing, but I know that I've seen some videos that are helpful in walking people through the process. All right, I think our next item here is language access. We talked about a decision tree that I think DMS is working on, and then last meeting, we specifically talked about making some recommendations for how to support the following populations, but not doing just one broad recommendation, really looking at 4 different groups: people who speak different languages, people who are deaf or hard of hearing, people with speech impairment, and people who are nonverbal. And I know that Miranda and Melanie in particular, and I think Arthur as well, were working on some recommendations here. Guess from DMS, is there any update on the decision tree? And then we can have a conversation about the recommendations.
It's still in progress. As the latest that I know. And looking at it and developing one. Now, as far as number 2 of A, I haven't been involved in anything of that part.
Okay. Miranda, Melanie, Arthur, do you have any questions or any suggestions here for the decision tree?
This is Melanie. Going back to your idea of a video, with especially with the individuals are hearing, deaf and hard of hearing, maybe having information on a video with closed captioning, so somebody could access it, being able to just read what is going on.
Yeah, that's a great idea.
And the same would be for a whole range of people that are nonverbal, in terms of, kind of with the frame of plain language, but maybe a video with that same kind of closed captioning information on it would help somebody to be able to access it.
Right. And the closed captioning could be in English and Spanish. if that's
Yes.
likely.
Oh, or there isn't, and this, I'm a techno peasant, but isn't there a capacity now to have something read to you while you're, uh, like a email or video, or, some kind of an announcement, you can push a button and literally the information is read aloud to you.
I've seen those programs. I don't know if that's a program that the individual has and applies to different web pages, or if the web page can embed something like that. That would be something to
Yeah.
I think some web pages can do that. And then I think some documents, depending on if it's a document, because I actually stumbled across that the other day accidentally, but then I thought, hey, this was kind of helpful to be able to listen to it. So I think depending on the document too, what it's in, if it's in Adobe or if it's in Word, that there's some capabilities of the program to do it too. I'm sure it may just be some education. Because like I said, I just kind of accidentally stumbled on it, I think, by hitting another button.
Mhm.
And
So
when we're
maybe one of our
preparing,
oh, I'm sorry. Was that David? Were you
yeah,
saying
hi,
something?
yeah. When we're preparing, trainings and other kinds of documents, we run it through a scrubber to make sure that screen readers can understand what's on the page.
Hmm.
So sometimes screen readers will say, "Oh, it's an image of a person at a desk talking to a man," or something like that. So there's various things. It's a lot to keep up with, but we're moving there.
That's really exciting.
Okay, well, one recommendation could be something related to standardizing the use of screen readers, closed captioning, subtitles, that sort of thing. It sounds like it's happening already, but maybe there are some documents or some forms that could use a little more attention. Any other thoughts here on language access? Should we discuss our recommendations now, or do you want to wait until the end? Miranda, you were about to say something.
The recommendations that I was working on, were really related to what to do with the decision tree once it's ready. So I was thinking along the lines of how it would be shared out, sent to Medicaid members, made accessible on web pages, but also sent to connectors, and that connectors be trained on the decision tree, and the training to include sample situations and connector and an opportunity to answer connector questions related to language access and the decision tree.
Okay, that's good to know. Rachel, you have your hand up. Did you have something else to add?
Yes, just that when we were talking about with the website, our DMS website is ADA compliant, so we have the screen reader already where if there are visuals, then part of any update when we post anything is we also put on there screen readers to explain exactly what the visuals are, things of that nature. So just to throw that out there so that way everyone's aware.
That's good. Thank you.
Thanks, Rachel. That's a better way of explaining whatever I said. I was trying to get there. Thank you, Nan.
All right. Arthur or Melanie, any thoughts on other types of language access? Okay. Well, then, Miranda, I'll ask you to repeat your recommendation, or maybe we can wait until we see the decision tree if you'd be more comfortable doing that. Oh, Arthur, can you hear us now? I'm sorry that you've been having trouble with your audio.
He says he's
He may
been
stop.
unable to hear anything for the past 10
I
minutes.
saw that, and maybe he still can't because we can't hear him right now. I'll just send him a message real quickly.
If he can't
Oh,
hear but
he
needs
just
to
he left it.
vote, okay.
So he might try to join again. And it sounds like we may want to just add this to the agenda for our next meeting. Hopefully there'll be a draft of the decision tree at that point that we can review and people can give a little more feedback on it.
I'm okay with, postponing the
Recommendation.
that I drafted, though I do have a question, if the decision tree is still in the works. Are the folks working on it interested in input on the decision tree itself? I'd be happy to thinking that I wasn't thinking along those terms when I was thinking about recommendations, but I'd be happy to send some thoughts if we know who's working on it.
Angie, do you have it? Do you know who is taking the lead on this?
Which one? I'm sorry.
The language access decision tree.
Oh,
If we
well,
wanted to,
from an equity standpoint, we're looking at it, and I believe where this is coming in through as far as connector, David Berry may be able to elaborate a little bit more on that side of things.
oh yeah,
We will, train the connectors in the community once we get it. We have done nothing on the decision tree itself.
to develop it.
Yeah.
Yeah, I was just wondering who's taking the lead on developing it, and if we could provide them with any suggestions kind of on the front end.
If you're asking me, it will be something I'll have to get back to.
I was originally asking Angie, but
Emily, I'll take
I'll take an answer from
find
anybody.
out.
Okay,
I'll find out for you, ma'am.
that sounds good.
All right, thanks, everybody.
Okay, so our next item is the MAC and TAC orientation packet. Thank you, Kelly and Aaron. I think the two of you worked on that together. I was able to review it. Hopefully other members of the TAC looked over that. I have a little bit of feedback, but I wanted to open it up to see if anybody else had thoughts or questions.
I had an opportunity to review it, and it was I learned a lot being able to read through it. So thank you very, very much for how thorough it is to see all the different leadership and different administrative staff within it. It was really helpful.
Yeah, I'm glad to hear that. That was the point of it, and I do really feel like the work that you all put into it is going to be something that every TAC and MAC member will benefit from and appreciate having as a resource. Some of the suggestions that I have are pretty simple, really. There were a number of places where I thought, oh, we could just put a link there, a hyperlink to a particular web page, or to some email addresses for some of the individuals that you identified. There was also, MAC and TAC statute and regs and the web pages there where I thought it would just be really easy to link to those. So I can send you this in writing, but that was really mainly the sort of opportunity that I saw, was to just link to more information for anybody who wanted additional details. Two specific things, well, actually three, and these are also relatively minor ones, but a couple of years ago, Lee Geis put together a table for us that showed the different types of Medicaid eligibility, because we, recognize that depending on your eligibility, that can determine how the program works, what services people get, or what that enrollment and eligibility determination process looks like. And eligibility would come up a lot in our conversations. And so this table was just something that was really informative. I thought that would be an easy thing to add in. And then linking to medically necessary services in the spa. I guess that's just another opportunity to link to more information. And then my final suggestion would be to include how people can request, how TAC or MAC members can request accommodations. Again, this is probably maybe 3 years ago now. We had a recommendation for quite a long time about making more accommodations, not just physical accommodations to the building itself, when we were having in-person meetings, but really making accommodations for interpreters, for personal assistants, that kind of thing. And that was something that Charlie had worked on. And I know there's a policy now, but I thought putting that into the PowerPoint would be good.
Hey, Emily, this is Kelly. If you and the other TAC members, whatever suggestions you have, if you could just send those to me in an email,
Yep.
I will get them to leadership and we'll see what we can do.
Okay. Yeah, that sounds great. Yeah, Arthur, we can hear you now. So I think your audio has gotten fixed. Thank you. Okay. Yeah, good. All right. Yes. Anybody who wants to add some suggestions to the list that I have, let me know, and I'll send those on to Kelly. I think we can move on to new business now. So we talked about language access in terms of the decision tree. Miranda brought an issue to us more specifically related to the workforce, and just wanting to know what, DMS, or what the cabinet, I suppose this could include KHBE as well, and DMS are doing to recruit connectors who speak more than one language, recruit for these different positions within the cabinet, and then anything related to frontline workers specifically.
Yeah, recruiting connectors who are multilingual is a very difficult nut to crack. It's difficult to recruit state workers, or even our contact center, who speak languages other than English, and surely other than English and Spanish. We're working it from every side that we can think of. In the short term, medium term, and even into the future. Before the pandemic, we had a partnership with UK to send interpreters out to connectors who were having events. It was not necessarily a one-on-one basis, but if someone was doing an event, they knew that a bunch of Ukrainian speaking persons or Spanish speaking persons were going to be at that event. And we do still have that contract with UK to utilize that service. We didn't use it a lot during the pandemic for obvious reasons, but we're going to kind of refresh that and send that out to connectors and stakeholders and whatnot, so they're aware and can maybe plan accordingly. We're also at the Outreach and Education Subcommittee on Monday, actually. They're looking at an immigration chart, which has a less wordy explanation of, if you're this type of immigrant type, what types of health coverage might you be eligible for. Everything from PE to emergency time limited to QHP, APTC. We even have a small blurb at the bottom about Social Security and that and whatnot. And then once that's kind of made its rounds and it's kind of approved, we can actually get that translated into, in addition to English and Spanish, 7 other languages. The ones that are most appropriate for persons who are coming from refugee kind of situations, Ukrainian, Bosnian, Swahili, Somali, and then French, German, Arabic, and Chinese, possibly Pennsylvania Dutch. There's actually a lot of people who speak that and do not speak English well in the Commonwealth. And we will also finally translate the Connect paper application into all 8 of those languages as well. The SNAP application actually is already in those paper copy, but we confirmed with our DCBS brothers and sisters that they can handle when an application comes in Swahili, they know what to do with it. And of course, the language line is always available at a contact center. So making more baby steps. But yeah, to be honest, we're open for any suggestions on how to recruit and then more importantly, retain persons who speak other languages. I'll pause and answer any questions.
I was on mute. Thank you, David. Miranda, do you have any questions or any suggestions here?
Thank you, David. It's really great that you all are intentionally making sure things are translated into more languages.
Yep.
One of the things on my mind is definitely recruitment of connectors and also state workers. And so I'm curious what kind of work you all have done to connect with communities of people who speak more than English, like who speak other languages, who can work in a job where they're required to speak English, but also speak in the target language. What efforts KHP has made to connect with different immigrant communities or organizations who work with immigrants, who work with people who speak other languages, to recruit more state workers or connectors into these roles.
I'm going to be honest, that's a fantastic question about intentional steps. And I can report back, or we will report back on what those intentional steps either have been or what will be. We always, when we're looking to recruit, we don't just go to UK, we go to K-State, we go to other community colleges. We try to cast the net across the board, but finding those intentional people within the foreign language speaking communities is tough. And just because it's difficult doesn't mean we won't do it. So love that as a suggestion and continuing to keep us sharper. So appreciate that, Miranda. And I will follow up with you. I do not have an answer right now for you. The interpreters who can go out from UK do include American Sign Language as well. We never actually sent someone who as a sign language interpreter. We almost did before the pandemic, and then the event got canceled, or the person, the assistance, whatever it was. But we're trying to accommodate people from across the widespread, especially those people of who are hard to reach. We found Somali is actually probably number 2 in Kentucky after Spanish, as far as people who speak that language but do not speak English, quote, very well. There are other languages that are higher on number of people speaking that language primarily at home. I think French and German, but they speak English at home as well. So we're trying to focus on those languages where the higher numbers of people are that are in the most need.
That's great. Another one of my I don't want to say concerns, but just something that I think would help is that even when we do have connectors who speak another language, indicating that in COG or the self-service portal, wherever that is, where a new connector responds to the questions and indicates their language. There's really, you can only enter one language. You can only enter English or Spanish. And so that when you're listed as a connector, you're associated with being able to speak English or Spanish. You can't put both. And so I think I'm listed as English, even though I speak Spanish. And so people looking for me who need to, yeah.
We sent that out last week. From your dashboard, if you go to my info, you can pick up to, I think, 13 different languages and mix and match. You can say you speak 8 languages now. So that went out last Wednesday or Thursday with little arrows on how to get there. It's through SSP now, it's not through COG. So it's a lot easier.
Okay.
If that's not working, please let me know. We'll pick up the phone and get on a Zoom call and see what's going on. But it's better. It's not just English and Spanish, but you can do multiple languages. So if that's not working, please let me know.
Okay, I just haven't seen that yet, but I'll play around with it and see if I have any feedback.
Yeah, so we need to know. Yeah, this is the best kind of feedback is when we were doing our debriefs, when saying we want good feedback. That doesn't necessarily mean good news. Good feedback could be, I don't know what you're talking about, David. It's not working. So let me know, Miranda. You should be able to do that, now. And that's exciting too, because if we get more people online who speak 3 languages or 4 languages, then they can indicate that as well and help point the way and steer people to the people they need to talk to.
Absolutely, yes, I'll explore and let you know. Thank you.
That sounds good. Thanks, David. Anything else related to that before we move on? Arthur,
Hello.
did you have a question about language access, Arthur, or were you going to talk about Michelle?
He was asking, because he's not feeling good, he wanted to lie down, but so he wanted to know if he leaves now, are you guys going to have enough people to vote?
I believe we still have 4 other TAC members on. I'm sorry you're feeling so bad, Arthur. I think we should be okay. Yeah.
He said he's sorry.
No need to apologize, but take care of yourself.
Okay. He said thank you.
I'll add the Michelle P. and other waiver conversation to the next agenda, Arthur. All right. Thanks, Arthur. Feel better.
How you get up? Oh, right here.
All right. So we'll skip Michelle P. And then the next item here, I think, Melanie, you had brought up the renewal process for children with SSI who turn 19.
Oh, yes, and thank you so much. I've just been in my world, I've come in contact with several caregivers or individuals themselves that had not gotten kind of a notification from either their school staff or SSI that when they turn 18, they need to reapply under the adult SSI. And the only way that they found out about it is when they went to access some service or something that they were receiving as a result of, like, I'm thinking of the waivers where you are required to have SSI to be able to apply for one of the waivers that they were not able to. And so they had to, what happened with a couple of families is they actually lost their status on the waiver, and it was just a hard kind of journey for the folks to go through. And I was hoping that there could be some ability to alert someone that's currently on the SSI that's for under age 18 when there is that time that they need to reapply for the adult.
Mm-hmm.
Does that make sense?
I think, yes, I think it does, without knowing sort of that back end process. But if Jordan Griffin, if you're still on, is that something that you're looking into in terms of this, work that you're doing at
Yes.
SSI?
Part of the changes, along with sending the pre-populated renewal packet for SSI terminations, is we're looking at creating a specific notice for our waiver individuals to kind of give them a heads up of the process, because that's something we're hearing a lot lately.
Yeah.
Our members and their parents are confused. They don't know what to do. They don't know where to turn. So part of that change that we're going to implement for the SSI terminations, we're looking at also creating a specific notice that will go out to individuals who are losing SSI. They may be 18 or 19. And it'll be specific to individuals with, waiver services who rely on that disability determination to keep Medicaid eligibility for the waiver. So that is something we've heard a lot of. We do understand that it's an issue, and we're looking for other suggestions above and beyond the notice, but that was just kind of the immediate go-to was, advance notification, that this is upcoming and what the process is from there.
Thank you for that, because I talked to several people that have actually had to go and had to go through that, but got a lot of help and support from you folks in helping them. But it's kind of like if you could do it proactively, that maybe that wouldn't be an issue. So notifying people will be a great help.
Absolutely. I think so too. Because it is just a lot of, receiving inquiries. They just say, we just don't know. We don't know what's going on. We don't know what to do. So the least we could do is kind of give them some instruction and help them through the process.
Oh, that's wonderful. Thank you so much.
Sure.
Yeah, I'm really happy to hear that you're working on that, Jordan.
Mm-hmm.
Let's see. The next item we have here is microtransit. That's another one I think that you recommended, Melanie. No, this is great. Great ideas. Microtransit for Medicaid members who are elderly or have disabilities. And I hadn't heard of this, so I'd love to learn more.
Well, I'm learning myself, so I'm not an expert, but there's in Lexington, there is an initiative they're working with communities, and it's not just for individuals with disabilities. It's for it's set up almost like a immediate response, like a taxi cab kind of service, because we have different paratransit opportunities that someone has to, put their request in several days before, and it's doesn't always work the way that you would hope it would. The microtransit concept is that it would be some kind of transportation support, and that's an individual could call and be able to schedule the appointment or on the same day, and be able to have someone to come and pick them up and take them to a specific location, like an appointment or something like that. And I listened to a presentation a while ago, and there seemed to be some possibility of Medicaid being able to cover the cost of that service, which I thought was really exciting. And I don't know what the status of that is, but individuals in my world that have physical disabilities or other kinds of needs, and elderly, and mothers with parents with children, I think that would be they're very interested in it. So the proposal is going through the steps through our city council right now, and I think there's a lot of support for that to move forward. But I didn't know if you guys had any updates in terms of whether or not Medicaid might be a if the person who has Medicaid would be able to use that funding stream, if you will, to be able to pay for the service, because it's very similar to what the bus fare would be, especially what I've heard is going on in Lexington. Does that make sense?
What I'm familiar with is non-emergency medical transportation, which is a Medicaid benefit, of course. And
Yeah.
there are 8 broker or regional brokers, I think 8, but regional brokers who provide that service or subcontract. I'm wondering
Right.
if anybody from DMS can tell us a little bit more about whether or not this would be part of an EMT, or if you're familiar at all with how this microtransit could work with Medicaid reimbursement.
Emily, I don't see, Justin was with us from policy for a few minutes, but he may have had to drop. So I can take that back
Mhm.
and get you guys answers on that. I don't want to misspeak on anything.
I think that sounds like a good plan. Thanks. We can just add that again to our next agenda. Any information in the meantime would be great. The next item we have here is health-related social needs versus in lieu of services. I know I've been learning a little bit about this. I don't think it's something that our most consumer TAC members or even other MAC and TAC members are probably very familiar with yet. It seems like there's a lot of opportunity here to start to provide reimbursement for, other types of needs that impact health, such as housing, food, maybe some types of transportation. And I think what would be helpful to understand more is where, the similarities are between, health-related social needs versus using in lieu of services. I know these are really technical terms, and I don't know if today is the day to do a presentation on it, or if maybe we should do that at our next meeting. But that's something that I'd really like us to kind of dive more into and really look at how we can make the most of this in meeting some of those social determinants of health that we talk about so much, or addressing.
You want a presentation from us?
If that's something that you'd be interested in, or Angie, if you can describe to us the differences between, health-related social needs versus in lieu of services. I've read a bit about both, and my understanding is that, CMS is really pushing states to do more to cover some of these needs that patients have that are directly impacting their health, such as an air conditioner, or something to improve their housing, or even make sure that they have housing, and then in terms of food, nutritious food, maybe it's Meals on Wheels, maybe it's a different kind of program, but looking at how Medicaid can cover some of those services for people who would be, determined eligible. But I've read about, both of these kinds of avenues, I guess, is the best way to describe it. And I don't really understand why you would necessarily go one route versus the other, and whether it needs to be an 1115 waiver or whether it can happen with a state plan amendment and that sort
It
of
can
thing.
be either. That's the thing.
For both.
In lieu of services can be a state plan amendment, or we can do the 1115 waiver, depending on what we would want for that to look like. It has been discussed at DMS. We are basically in the investigating stage of that on how or if, when to do that. We've heard of food as medicine, and we have done a study or two. California's ahead of doing a lot of things. And I know as far as in lieu of services, we've looked at them. There's a few other states that are doing that as well. So we're doing what I would say at this point, we're looking to see what other states are doing and how we could potentially add that either through a spa or through 1115, but we're in the infancy stages of that at this point. You know, health-related social needs is an individual, as, you know, based on the individual, or social determinants of health is more of a group. So we're doing a couple of pilots with, well, we aren't. Some of the MCOs are doing pilots on with food and housing, and I think maybe transportation. I could be wrong on that one, but and to see whether or not that is something we could look at that would be futuristically we would pay for, in like for transportation instead of, I don't know. See, that's the part. How would that exactly look? And if we were to pay for food instead of a doctor's appointment, that's kind of where that all, it's kind of gray. So at this point, it's very new to us, but it has been explored. It is being explored.
Okay. Well, we might leave this on the agenda just to get updates as you are learning more, and if there's anything that you're working
Emily,
on.
this is Leslie. I think Angie's totally correct. We're just now starting a deep dive. As you know, we had some pieces for social determinants of health in the 1915I. We've got pieces here and there. Angie's also been working on some things, but we're just now like trying to take a deep dive. Your next meeting might be still a little premature, so give us a little bit of time to try to figure out what it is we want to do. We're not opposed to trying to assist. Angie and I've talked about the food allocations several times. That is something that even behavioral health, when we were doing the eye, we talked about that as well. So just give us a little bit of time to really dig into it and to let you know kind of where we're going to go with that, if that's okay. And it will be a joint effort between our group and Angie's group.
Okay, that's good to know. And I think it occurred to me that this might all sort of tie into what Veronica was talking about on our last call, you know, with aligning all the quality initiatives and the work being done around social determinants of health, and this would probably fit right in there. So that may be a conversation that we can have kind of with those two items in mind. Looks like we've covered all of our new business. Is there anything else that our members want to discuss, or any other updates that DMS wants to provide? I did want to just ask members if you're getting all of the emails that Aaron, it's generally Aaron, maybe they come from Kelly or others at DMS from time to time, but there have been some emails recently, two come to mind. One was related to Medicaid in schools and getting feedback from schools. And so I want to make sure that, you know, that survey is getting sent out far and wide to school officials. And Christy, that may be something of interest to you in particular, with Bullitt County Schools. That would be to really look at how we can expand access to Medicaid services in schools. And so that's an
I got another
exciting
email on that
project.
from somebody else today as well.
Oh, good, good, good. Well, and there's a grant that's available right now from CMS, and my understanding is that Kentucky is applying. But all of this is going to happen really quickly because the grant didn't have a very long
Emily, this is
application period.
Leslie. We are partnering with DBH to take a look at that grant right now. So I just wanted to let you know that we'll have more to come on that very soon.
Okay,
There's
great.
lots of moving parts right now and lots of
Yeah.
opportunities out there. So yes, we're taking a look, and I think like you said, the survey is very important. So that will help us build upon a needs assessment later. So make sure that you can advocate for us to get those surveys in.
Well, I'm glad to hear that. And then, so if any TAC members aren't getting those emails from Aaron, let us know so that we can make sure that you're on that that distribution list. The other email that I got just today, maybe yesterday, was from Elizabeth Fisher about Medicaid stories and collecting stories, specifically related to K-CHIP and postpartum expansion. So having postpartum care for up to 12 months or a minimum of 12 months. And if anybody has any individuals in mind for that, that would be something else to share out to your networks. If there's nothing else to discuss, we can move on to recommendations.
Did we
It sounds,
go over process to overhaul Michelle P and other waivers?
we were skipping that because Arthur wasn't feeling well.
Okay, just making sure.
Yeah, so we'll put that on the next agenda. But thank you for catching that. I had two thoughts for recommendations. Does anyone else have any recommendations in mind? Oh, and in fact, one of them is something I made a note to myself and I forgot to bring it up. I had heard that their DMS may be doing a survey of Medicaid members. And I think that's fantastic. Number one, I don't recall Medicaid members ever being surveyed by DMS directly before. I think the consumer TAC could have some good input into the development of that survey, certainly disseminating it and evaluating it too. But if there's an opportunity for us to have any input into what questions are being asked, that would be great. Is anybody on from DMS who's working on that survey by any chance?
Yeah, Emily, this is Beth Fisher. I am familiar with the survey and will have certainly assist in distributing it. And I think that we could definitely share that. It hasn't gone out yet. It's still in the approval stages. So I do think there could be some opportunity to share with the TAC and to gather more input. But I'll check on that for you.
Thank you for checking. And if it needs to be a quick, 48-hour turnaround, we can do that.
Okay.
But just having a quick look at it. One thing I'll share, and this is a little bit outside of the TAC, but KVH is going to be doing some listening sessions. I had shared this information with Commissioner Lee a few weeks ago, and she was really interested in, maybe collaborating in some way. And so when I heard about a survey, I thought, well, perhaps these two could kind of work in tandem in a way. But also just interested in seeing, what kinds of questions that you're asking and thinking about it in terms of plain language and all of that. So yeah, if we can have any input, I'd be happy to look at it quickly and get feedback to you quickly. So I won't, that was a note that I made to myself, but I won't make that as a recommendation. The one recommendation that I wrote down from our conversation today was about creating more video explainers and standardizing the use of screen readers, closed captioning, and subtitles. Is that something that the group would like to put forward as a recommendation? Okay. I saw Christy shaking her head, so I'm going to take that as a yes. And I will just repeat that again, and then I'll ask for a motion in a second. And I think I'll preface it by saying to improve language access, the consumer TAC recommends that DMS create more video explainers and standardize the use of screen readers, closed captioning, and subtitles on DMS web pages, materials, and forms. Now, I didn't write that all down. I just had a much shorter version that I had made a note to myself, so I'm not going to be able to repeat it, but it's a good thing we have a recording. Hopefully that captures what we were discussing earlier. Can I get a motion for that?
I move that what you have said.
Make that recommendation. Thank you, Melanie. Perfect. A second?
I second that recommendation.
Thanks, Christy. All in favor, say aye.
Aye.
Any opposed? All right, the motion carries. Any other recommendations that you want to put forward? All right, well, hearing none. The next item we have on the agenda is for MAC meeting representation. I'll plan to be at the next MAC meeting to provide a report for the consumer TAC. And then our meeting schedule, I always include here, just so that people are aware and have it on their calendars. Our next meeting will be April 16th. And we can adjourn. Can I get a motion to adjourn?
Make a motion to adjourn.
Thank you, Christy. A second.
Second,
All in favor, say aye.
I.
Any opposed? All right, we are adjourned. Thank you all. Have a good afternoon, and I'll see you in April, if not sooner. Bye.